And what you're about to see is an interview of an older man who's an inpatient in a psychiatric ward. Um, you should be able to obtain a lot of information from this interview. You need to treat it as a diagnostic interview. You should be able to make a differential diagnosis from the history obtained by the interviewer. It's also important to concentrate on the mental state examination and to be able to give a good description of the symptoms and signs that the gentleman presents. It's also worth focusing on the style of the interviewer and making comments about how they function during the interview.
Right. Now, I'm interested specifically in why you came into hospital and how you've improved. You've improved quite a lot since coming in.
Oh yes,
Yes, you have. Do you remember what you were like before you came in for treatment?
well, I had a lot more to do because I lost the wife
Right. And
about 5 years ago,
5 years ago. Uh-huh.
and I had a lot more to do there. Of course, I've had I've had Parkinson's disease
Uh-huh.
for 5 years or more.
Right. Okay. So,
Uh,
before you came into hospital this time around, were you sleeping well at nights?
I can't remember that, to tell the truth.
You can't. Okay. I'm going to try to jog your memory just a little bit. All right. Um, were you? How was your mood? Um, before coming in, were you feeling low in mood, or were you just feeling like you normally do?
I think I was a bit low,
You were
bit on the low
a
side.
bit on the low side. Right. Okay. So up to the point where you came in, you were feeling depressed.
Yes, that's the word.
Right. Okay.
Did-
Did you ever have any thoughts of harming yourself in any way or ending your life?
I did it once.
You did it once. What was it that you did at that time?
I felt very, very, very low.
Yeah.
In fact, in fact, I wouldn't be here now if it hadn't been for the lady mm, 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 next door.
Uh-huh.
She, she, she came upstairs, and I was on the bedroom floor.
Right. Okay. What was it that you had taken or done?
Well, it was the same old life. No, with no change or nothing, you know.
Uh-huh.
Same life. And
Mhm.
they got me down.
Yeah.
They got,
So what did you end up doing as a result of how you were feeling?
oh, I tried to swallow some pills.
Mm. Do you know what it was that you swallowed?
If I could go on,
Mm.
it was what was the name? Pills,
Painkillers,
painkillers,
medication.
painkillers.
Mm. About how many it took you?
Quite a few, I'll tell you.
Mhm. What were you trying to do when you did that?
Well, it was obvious
Mhm.
that I was trying to commit suicide.
Right. Okay.
I think so anyway.
So you definitely wanted to end your life.
I did that day.
Mhm.
See, me and the wife was being away was attached well to each other,
Yeah,
you
that
know.
must have been difficult for you. Did you regret being phoned?
But,
Did you
well,
regret the fact that you were phoned by someone? That you didn't actually die?
well, and now, and in fact, now I think that I
Okay. Do you think that you would ever try something like that again?
No, I don't think I would.
And why is that?
Well, I got more people who to talk to
Mhm.
now than I did.
Okay.
I lost a wife 5 or 6 years ago.
Right. So you were feeling a bit isolated,
Yeah, I did, yes.
but not now, is it?
I never see nobody.
Yeah. Okay. That must have been difficult. When you came into hospital, you had some ideas.
Pardon?
You had some ideas. I remember you telling me that you thought that you had cancer. Do you remember that?
That's right, yes, I did.
Mhm. What exactly did you think that you had?
Well, you feel like anything. You feel like anything to think that you've got cancer. Cancer. I think that was a part of the way that I would try to commit suicide.
Right. You think that's part of the way you would try to commit suicide?
Yeah,
I'm not too clear on what you're saying there.
well, people who tried to tell each other about me,
Mhm.
and it got around that I had the cancer.
Okay. So you thought people were talking about you and saying that you had cancer.
That's right.
Right. We just want to pause to wipe there. Right.
This, by the way,
Mhm.
this terrible is is a sideline
Mhm.
of the treatment I'm having.
Right. Okay. We'll work on your medication. So you do you still think that people are talking about you and saying that you have cancer? Do you feel that way now?
Well, it's a job to say, really.
It's a job to say.
It's a job to say.
Is that a yes or is that a no?
Yes, I think it is.
You do. So do you think that you have cancer at this point in
Well,
time?
I don't know.
Uh-huh.
In fact, I don't really care.
You don't. and what has made the difference? You say you don't really care now. Why is that?
Well, and I've had my life, really.
Uh-huh.
I'm 86, which is a good age, really.
Mhm.
And I find that there's no change in my life now, you know what I mean?
Do you feel like your life is worthless at the moment?
Well, it's not worse, but it isn't any better.
Mm.
At the present now, I'm talking,
Mhm.
I really should be in bed. I feel very hot and clammy. Hot and clammy.
You're feeling hot and clammy now.
Hot and clammy.
How is your mood right now? Are you feeling
Low.
You're feeling low right now.
That's right.
Uh-huh. Have you been eating within the past few days? How's your appetite been?
Well, I've been eating all right, but
Eating well? Or eating?
I've been eating well, really, yes.
Okay, I've been asking you questions for a while. I'm going to try to end it now. But just before I end, I'd like to find out, there was a point where you thought that men were coming into your room and talking at night?
No, I can't remember that.
You can't, alright.
I can't.
Uh-huh.
In fact, I had the only people who come and see me really was my in-laws, really.
Mhm. Okay. So you don't think that anybody was coming into your room at night and?
Oh no.
Right. Okay.
The only people who used to come and talk for a short period who
Were the staff?
was the neighbours.
The neighbors. Okay. Do you know what month we're in right now?
Oh yes.
Uh-huh.
In December, anyway.
Right. And what's coming up soon?
Oh, Christmas.
Yeah. Do you know what year this is, Mr. Warrender?
Oh, 2000, isn't it?
Yes, that's right. And do you think that the treatment here has been helping you?
I can't say that. And I can't say that.
I'm sorry, can you repeat that?
I can say it hasn't really.
It, it hasn't or it has?
Well, there's not much change.
You don't think there's much change in you?
But at the present time, I say I'm hot and clammy
Mm-hmm.
and and low.
Right. Do you think this is all because of your Parkinson's or is it something else?
Well, and the Parkinson is a cause of it, I think, because I know that that's a thing that I won't get any better.
Okay. And what's the name of the place that you're being treated at? What's the name of this place?
Now you got me there.
It's not a trick question.
It starts. It's a W.
Mm-hmm.
Good.
What sort of place is it?
It's an hospital, isn't it?
Yeah, okay. It's Wexham Park Hospital.
Wexham.
And where is it located?
Pardon?
Where is it located? Where is it? Where is Wexham Park Hospital located?
It's close to Slough, isn't it?
Right, okay. Thank you very much. You've done very well.
Just thinking about his sort of physical problems, what are the physical problems he has?
Right, I think the main one was that he gave a history, I think it's 5 years, of Parkinson's disease. And in fact, that was quite evident when you actually saw him on the tape, because even from the very beginning, you could see that his facies was quite Parkinsonian, lacking in reactivity. He had a very sort of hesitant speech, which was actually slightly reduced in volume, and also sort of nearly festinant, in fact, a bit like people have with Parkinson's disease when they walk. And he was also dribbling as well. And there's at one point, actually, the interviewer allows him to actually wipe his mouth with a handkerchief because he's dribbling so much before carrying on with the interview. So those, I mean, although we don't actually see him walk or get up from the chair, just by actually looking at his posture and his faces, and it comes across there quite clearly.
I mean, are there any differential diagnoses to think of with that sort of presentation?
Well, I think with him, I think there was probably a range of differential. He was admitted following a suicide attempt. I think probably in view of that and taking into account his symptoms, depression is probably the number one diagnosis. He also had psychotic symptoms, so you could think of another psychosis. It could be psychosis as part of his depression. It could be a psychosis as part of Parkinson's disease. You can get psychotic symptoms in Parkinson's disease. It could be a delusional disorder of late age. It could be a psychosis independent of depression, or it could even be the psychosis in the beginning of a dementia. So you could consider a dementia. I think in someone of his age who's presenting with psychiatric symptoms, you always need to think of an organic, possible dementia at the back of your mind. So I think those would be the sort of main sort of diagnoses you'd be sort of thinking through.
What are the features of Parkinson's disease?
Well, the main features are it's a rigidity, a tremor, which I don't think you see much of his hand, so you can't see that obviously in his case, and a sort of the slowing of the gait.
Just thinking about the physical conditions, is there a sort of differential diagnosis, or is that it? There's just.
I mean, I think he had made comments that he'd got a lot of pain, which was actually one of the reasons why he'd become convinced that he had cancer. The fact that he actually put that across quite well, and he got to the extent that he thought other people knew he had cancer and were talking about him having cancer. And so he did have quite a lot of pain. Now the pain may well be actually a genuine somatic pain that he experiences, or sometimes when people get depressed, they do get physical symptoms like pain, or physical symptoms like pain can get a lot worse when your mood's low. So it is possible, that there are other physical problems which are producing that symptom.
But it's unlikely, is it?
I think it is. I don't think that would be your number one sort of diagnosis. And I think he, in trying to establish, whether his fears about having cancer were genuine. He had had investigations and to exclude, you know, any other obvious sort of physical disorder.
Thinking about the psychiatric side of it, what are the symptoms that we should be paying attention to?
Right, okay. I mean, he actually came out with feeling low mood and depressed. He talked about insomnia as actually, I think that was one of the main symptoms he first mentioned when he was being interviewed. He did talk about appetite, which I think he explained was reduced. And he talked about a general sort of lack of enthusiasm for life and a general loss of interest in life and actually feeling that maybe there was no point going on. And he talked about the fact that he'd actually attempted to commit suicide. He actually talked about taking an overdose of painkillers, which he actually explained as a way of killing himself. And even towards the end of the interview, he still talked about questioning whether life was worth living or not. So that was still a thread that was persistent there. So from the depression point of view, those were the main sort of symptoms that he talked about in the interview. He did refer to, and it had to be prompted a little bit by the interviewer with regards to psychotic symptoms, and those were particularly, it was a conviction that he had cancer, and also the belief that people were talking about him and actually everyone knew that he had cancer when in fact that wasn't the case. And I think there was also reference to him having other persecutory ideas about people. I think it was breaking into his flat, which again was not based on fact. So there was a very strong suggestion that he had at least delusional ideas as well, particularly of a sort of persecutory nature. But he also made references, which sort of fits in with the depression, to ideas of sort of guilt and punishment and that sort of content.
Tell me about the psychotic symptoms. I mean, does that occur in depression?
It certainly can occur in depression, yes. I mean, it's really associated with severe depression. You wouldn't expect to get psychotic symptoms in mild or moderate depression, but certainly in severe depression, they can be a very prominent feature. And in his case, that was an example, I think, where he'd actually got ideas which had become delusional, and he was actually quite convinced they were true. Although actually by the time he was seen in the interview, he'd had treatment, and therefore there had been an improvement. But yes, I know psychotic symptoms can be very much a major feature of severe depression.
Several times through the interview, he's talking about what's the point in going on. I mean, how do you sort of respond to that?
I think that's interesting because, in fact, actually in the interview he made several references because although he referred to that again towards the end of the interviewer had actually asked him a bit about that, and he had actually when he was questioned about whether he would try and kill himself again, he did talk about actually having a change of view about that, and actually the fact that I think it was he had more social contacts now, and that was something that was making him feel sort of that there was sort of more to life than maybe he'd originally thought. But I think it's about clarifying, you know, when a person makes that sort of comment, you know, is there any point going on? It's really clarifying why they're thinking like that, and what is it that's making them not feel like wanting to go on, but equally what's making them feel like they do want to go on. I mean, what are the positives that might inspire the person that life is still worth living, and then trying to look at what those can be manipulated in order to try and actually produce the best outcome for the patient.
Do you feel that that's a sort of hot topic in old age psychiatry?
I think I do think it. Yeah, I think it's very much part of old age psychiatry, and I think as you get older, I mean, we can have losses throughout our life, but as you get older, you're put in a position where you may be exposed to multiple losses. So, I thought he was quite a good example of that. He'd lost his wife, and I think they'd been married for a very long time, and obviously quite a close couple. He'd lost physical health. He'd actually got Parkinson's disease, and he'd got pain. He'd lost in some ways some of his mental health, not only with his depression, but there was some evidence of some memory problems as well. And he'd become socially isolated. He wasn't working anymore. I can't remember when he retired, but it was some time ago. And therefore, you know, he was a very good example of multiple losses. And that's unfortunately one of the things that you do get exposed to as you get older. So that aspect of an older person's life is very relevant to how they present and how you can actually then look at enabling them to improve and their condition get better.
I'd like to talk in general about how to treat someone like that.
Right, okay, yes. I mean, I think when you're looking at treatment, I mean, I suppose in psychiatry, whatever the age of the patient, you're looking at physical treatments, psychological treatments, and social treatments, and that's just applicable to someone who's 20 as it is to someone who's 86. And maybe in the case of this gentleman, all three are very relevant. So if we're looking at physical treatments, there's two aspects there. There's his physical health and there's his mental health. His physical health, he's someone actually who's already on treatment for his Parkinson's disease, and that actually had been established before he presented to the Department of Psychiatry. But that does have a bearing on his treatment of his mental health, particularly the physical treatments. And then you're looking at the physical treatments of his mental health. Now, in order to formulate a treatment strategy, you have to have a diagnosis. And I think with this gentleman, the working diagnosis would be a severe depressive episode with psychotic symptoms. So the mainstay physical treatments would be an antidepressant, plus or minus an antipsychotic, and the possible consideration of electroconvulsive therapy, ECT, depending on how the patient progresses. The problem in treating treating a gentleman like him with antipsychotics is that one of the side effects of antipsychotics is Parkinsonian symptoms and signs, and he would be at risk of an exacerbation of his Parkinson's disease by using antipsychotics. So you'd have to be careful in whether you used them, the dose you used, and which particular antipsychotic you used. If you then move on to the sort of psychosocial side of his management, there may well be issues that he needs to explore about losses, particularly the loss of his wife and the bereavement that involved. And also maybe spending more time talking through him, particularly when hopefully his mood improves through the meaning of life for him and what is important for him and how he would want the rest of his life to be lived. And I suspect a major part of that is going to be the social aspect, and he was living on his own, and it's whether that's something he wants to return to, whether he's physically able to do that, whether he's mentally able to do that, whether he wants to do that, or whether he would benefit from a social environment which is maybe more stimulating, in which he actually gets more social contact. So I think that would be, in a general sense, that would be the sort of framework of how you would actually look at treating someone like that gentleman.
Tell me a bit about how to interview someone like that.
Well, I think the first thing is what you need to do. You have to let the person know the purpose of the interview. I think that's the first thing, because if they think the interview is about something completely different to what you're trying to get out of it, then that's not going to be a good start. You need a relaxed environment, and the patient needs to be comfortable. I think there's some quite good examples in that interview. The gentleman was a little hard of hearing, and it needed several times for the interviewer to just maybe repeat the question or slightly rephrase it so that they could hear it better. And that's important, because sometimes people who are hard of hearing may just say yes or no because they want to give you an answer, but may not have heard the question. So you saw examples of where the interviewer was actually repeating the question. And give time as well, time for the patient to answer. And he was clearly having difficulties with his speech. He had the constant dribbling, which you could see, and he needed the space to think about what he was saying, to get what he was saying out, and also to deal with the dribbling. So it's making sure that the patient's comfortable. And then it's trying to ask questions in a way that are not too closed, certainly initially. And I think sometimes when you're under pressure in an interview, you tend to hone in on the closed questions, maybe sort of restricting the amount of time a person has to answer a question openly. But it's important that you let the person say what they want. But then you do need closed questions to make sure you get all the relevant information from the interviewer. And I think, to some extent, reassurance. During the interview, trying to reassure the person that they are giving you information, and I think that gentleman was quite keen at the end to know that he'd done reasonably well from the interview. I think he'd seen it a little bit as a trial.